chemical equation is not being undergoing as much. So those numbers can go up and down, and you have to think about where they're coming from. BUN, if it's low, is probably the liver. Creatinine, if it's low, is probably the muscle. There's not a lot of muscle mass in that patient. Alright, so this is the chart that kind of changed the way I did everything as far as fluid therapy. So in human medicine, they measure your GFR. And this is a very complicated, not complicated, but you have to read, you have to know how to read it. GFR would be maximum here, okay? 120. Let me go from the computer. 120, right? 120 ml. MLs per minute. You should be clearing your plasma into your urine. And that would correspond, let's say, to a BUN, the red one, of maybe 20, and a creatinine of maybe 1. Okay? So you have to look at this chart very carefully. And so, as the GFR drops, it can drop 50%, right, from 120 to 60, and you don't get an elevation in BUN and creatinine above normal reference ranges. It will always start changing when you get 75%. 75% of the original GFR. That's when the numbers start changing here and here, right? And so that's how insensitive BUN and creatinine are at determining the amount of drop in glomerular filtration ratio. It's a pretty powerful chart in saying, you know, it is what we use, but it's not the best. So in a human, they would measure GFR and get you before your creatinine and BUN is elevated. They will assess how much you have dropped in GFR before that and intervene. So we have tests now like the SDMH, right, that will not require 75% of your GFR to drop before it gets elevated. SDMA is another marker, and we'll talk about it more later, but it's another marker like BUN and creatinine. But it gets elevated instead of at 75%, maybe at 40% drop of GFR. So it's more sensitive, so it makes sense to use it sooner. But I'm teaching you the core basics here. BUN and creatinine is what you're going to get on chemistry. You're not going to get on SDMA yet, okay? But it's the same principle. It's a marker, a biomarker. Okay? I'm not going to go over GFR studies. If you have any questions on that, you can ask me, or shoot me an email. But that's kind of irrelevant. I don't think Renal will ask you. I think this chart is what is relevant to relate GFR to BUN and creatinine and maybe an SDMA. Because this is what you're going to explain to the owners. The owners look at the creatinine and go, it's only 1.9. And it can go up to 2.1. Yes, it's going from 0 to 75% crap out. We are probably at some point 60, 70% crap out, and we're not identifying it. So normal for BUN and creatinine is not normal for me anymore. If I have a patient that's hospitalized, and the creatinine is 1.3 today, and it's on fluid therapy, and I come in the morning and they check it again and it's 1.8, it's still in the normal range, I freak out. I'm like, that jump of 0.5 means that this happened. Somewhere here, we're still below the threshold for this thing to go above normal range, but I dropped my GFR a lot while being on fluid therapy, so we have a problem. Follow me? You gotta start reading between referent ranges and rather than outside of the referent ranges if you want to save animals with failure. Another test for GFR, or let's say another test of glomerular function, and Dr. Martin will talk to you ad nauseam about this, would be glomerular disease. In a very simplified fashion, you're assessing for protein and blood in the urine because you have problems at that interface between the basement membrane of the Bowman's capsule and the endothelial gaps that enter, and separate that blood and fluid and cells in the glomeruli or in the vascular tufts in that capillary. So if that interface is deranged, let's say because you have antibodies here affecting this, then you're going to start leaking protein, red cells, white cells, and then you have glomerular disease by definition. So seeing protein in the urine or seeing blood in the urine, it's potentially a marker of glomerular disease, okay? And so now we can move on from glomerular disease to tubular function. So we worked on glomerular issues, GFR, and then glomerular structural lesions to tubular function. Before I depart from here, just because you see protein and red cells in the urine doesn't mean that you have glomerular disease, right? You have to rule out other things first. Like what? Yeah, so a urinary tract infection. It could have been lower, right, instead of upper. So that's why before you submit a test like a UPC, a urine protein creatinine ratio, which is the gold standard for glomerular disease, you have to make sure that the animal doesn't have a urinary tract infection, or that you went in and did your cysto and hit an artery going in. Make sense? But again, Martin will talk to you a lot more, so I'm just going to give you, I just gave you that overview. All right, tubular function. So here, has everyone used a refractometer? Yeah? So refractometer, you will see two columns. SP is for serum proteins. Same instrument, you can use it for blood or use it for urine. SP serum proteins, and UG for the specific urine gravity, okay? So same instrument, two different reference ranges. If you use it with urine, you will focus on the specific gravity here where it says 1, 1.0, 1.10, 1.20, 1.30, 1.40. And as you get lazier with life, you start saying, well, that urine is probably 1042. Not really 1042, it's 1.042, but it's a lot easier to say it's 1042. But in any case, I'm not looking at the serum proteins, right? So I'm not measuring serum, I'm measuring urine. So that's important. When you see a refractometer, you're going to see two tables inside what you're looking at. Just make sure you focus on the correct reference table. That clear? And if you want to report it, hey, the urine is 1.042, but know that between clinicians we just go 1042. We just become lazy. So what does that mean? The specific gravity would be a weight thing. And right is gravity, it's weight. We're making an assumption that if we have a heavier urine, we have more osmoles in it. An assumption. It's not real. Ideally, I would measure the osmoles in the urine, but we don't do that. Why is that? Why is that important? Well, we assume that the urine will have a lot of, well, it will have some sodium, it will have some BUN, it will have some creatinine, right? Crap that we need to excrete. And they all kind of weigh more or less the same. So it's more the number of particles rather than the weight of the particles that will dictate my specific gravity. Let me change the game now. Let me say, what if I give mannitol to this patient? Mannitol is a huge sugar molecule. Where is it going to end up? In the urine. Isn't that going to increase my specific gravity just by the weight of it? Yes. So it will bias my number towards higher specific gravity, even though I really don't have a lot of particles in that urine. That makes sense? So even though we're trying to assess the osmolarity of the urine, we are really measuring the weight of the urine. And that's cool, no problem, until you start using mannitol, until you start using hetastarch, right? That's another big molecule. Until they get ethylene glycol and they start peeing ethylene glycol, until they get getting stuff that shouldn't belong to your body, then those things are going to affect your refractometer reading to a point where you can't use them. Whatever number they tell you is going to be unreliable. That's the bottom line. But if you have a patient on fluids, sodium, chloride, potassium, vomiting, diarrhea, renal failure, then you can use the refractometer and make the assumption fairly accurately that the weight of that urine equals the osmolarity of the urine. So that's where you start getting into the urine-specific gravity, where you say isostenuria. So isostenuria would be between 1.007 to 1.015. Typically, it's 1.012. I don't know why. But just know that number because it's really important. That means that this dog or cat filtered out the blood through the glomeruli, and that fluid, or that urine, quote unquote, didn't get modified at all by the tubules. Okay? Nothing got absorbed, nothing got secreted. And that's isostenuria. So an isostenuric urine in the face of isothemia would indicate what? Probably the kidneys are not working, right, as they should. So not only my GFR dropped, and so I have creatinine and BUN elevations, but my tubules didn't do anything about it to modify that urine, so it stayed isostenuric. What if my BUN and creatinine is high, but my urine has a specific gravity of greater than 1.050, like it has a lot of osmoles? It's pre-renal. Maybe the kidneys are not getting enough plasma or blood volume, and so the BUN and creatinine goes up, but the tubules are working overtime and doing what? Pulling water away from the tubules into the blood. And so what remains of that urine is a really salty urine, and that's what we want, right? So that would be pre-renal. That would be a good thing. This animal is doing what it should. Let's say the same animal that now we know is pre-renal isotemic, we put him on fluid therapy, right? That would make sense. What should the urine be the next day if you fully hydrate them? The specific gravity, should it still be 1050? No, it should be isostenuric. You diluted the entire medullary concentration gradient that I taught you the first day. You did that with fluid therapy. That's your job. So one way to assess proper hydration in a patient on fluids is measuring their specific gravity daily, even if it's free catch. It started at 1050, well, 24 hours later it went down to 1012. Great. I know I hydrated this animal properly. All right, let's jump into page 9. Very briefly, we'll go over a CBC. What should you expect in a CBC of a patient with acute renal failure? So a CBC has three rows, right? 3 cells that you assess. Number 1, red blood cells, hematocrit, same thing. Red blood cell count, hematocrit, same thing. I will go for the hematocrit. Same, because we use hematocrit much more than the red cell count. That's a human thing. So hematocrit / packed cell volume. Second thing, what would it be? White blood cell. And then within that white blood cell line you have neutrophils, lymphocytes, eosinophils, how much? But it's white cell count, right? And then the third thing, platelets. Cool. So what should I expect with the red cell count / hematocrit / PCV if I have acute renal failure?
Normal.
It is normal. There's no reason to be anemic because you haven't had enough time for your erythropoietin production to drop. So they have a normal. In fact, it could be elevated if we have dehydration. Okay? Cool. So if you have chronic renal failure, then you get anemia. What about the white cell count? It could be normal if it's a chronic, slowly degenerating insult, or it could be high if I have leptospirosis, because I have an inflammatory infectious process going on. So it could be variable. And your platelets, variable too. So the big one for renal failure would be the red cell count / hematocrit / PCV, okay? Any questions there? I think I'm going to stop, but this is a lot of stuff, right? But it's good stuff. This is good stuff. This is, I think in clinics, if you can get a good grasp of the first 3 lectures at least, you are gonna be able to manage a renal failure patient. Not only diagnosing and go, oh, it is renal, great. Now what? You know, like, I want you to get to the what. Now I'm gonna do this because of this, right? Chronic renal failure is a pain in the neck. For that you need an internist. But for acute, and more specifically for the pre-renal ones, the ones that you're gonna see way more than I will, vomiting, diarrhea, pre-renal, when the kidneys are still healthy, you're gonna be able to make an impact. And that's kind of my goal. If you have any questions, just shoot me an email, okay?